This is week 4, organogenesis of the alimentary, urogenital, and integumentary systems. The learning objectives for this week are to explain the development of the alimentary system, including the esophagus, the stomach, the duodenum, the liver, the pancreas, and the spleen, to define cloaca and related anomalies of development, explain the development of the urogenital system, including kidneys and ureters, gonads and gonadoducts, describe timing and genetic and environmental factors that result in disorders of ambiguous genitalia, explain the development of the integumentary system, including skin, hair, nails, and teeth, and give examples of disorders resulting from changes in integumentary system development. This week, please go to the embryology self-study and look over the sections which are at these links for the digestive system, the urinary system, and the genital system. A cloaca is a common passageway for feces, urine, and reproduction. At one point in the development of the human embryo, there is a cloaca present. It is the far end of the structure called the hindgut. This structure then divides to form a rectum, a bladder, and a genitalia. The presence of a cloaca is normal in many adult animals. However, the persistence of a persistent cloaca in a person is a birth defect. Esophageal atresia occurs in about 1 in 3,000 to 1 out of 4,500 neonates. It's approximately 1/3 of these children are premature. In most cases, the upper esophagus ends and does not connect with the lower esophagus and the stomach. In 90% of the cases, it is associated with tracheoesophageal fistula, a TEF, which is an abnormal connection between the esophagus and the trachea. The symptoms of esophageal atresia are a frothy white bubbles in the mouth, coughing or choking when feeding, vomiting, blue color to the skin, especially when the baby's feeding, difficulty breathing, and a very round, full abdomen. Please go to the Children's Hospital site to look at a talk about esophageal atresia. Esophageal stenosis. If we look at this, we have a disorder called congenital esophageal stenosis, CES. It's a rare anomaly. The incidence has been estimated at about 1 per 25,000 to 50,000 live births. It results from an incomplete separation of the respiratory tract from the primitive foregut at the 25th day of life. The first clinical signs are abnormalities of the swallowing mechanism caused by the intrinsic narrowing of the esophagus. In looking at hypertrophic pyloric stenosis, the pylorus is this muscular sphincter located where the stomach joins the first part of the small intestine, which is called the duodenum. Normally, the pylorus contracts to keep food in the stomach for digestion and relaxes to let the food out into the intestine. But for reasons that doctors do not fully understand, the pylorus becomes thickened and sometimes closes off. This is referred to as stenosis, and it's called pyloric stenosis. This blocks the material from leaving the stomach. This blockage usually occurs in the first month or 2 of life. The thickened muscle creates a partial blockage, an obstruction that interferes with the passage of stomach contents into the small intestine. Infants feed well, but they vomit forcefully. They have projectile vomiting shortly after eating and can become dehydrated and undernourished and often show up at a ER or a doctor's office with failure to thrive. The diagnosis is based on results of an abdominal ultrasound. Typically, the problem is corrected by fluids given by vein and by minor surgery. This disorder has the risk factors of the male sex, especially firstborn boys, parents or siblings who had pyloric stenosis, use of certain antibiotics, for example, erythromycin during the first few weeks of life, smoking during pregnancy, and this disease is inherited in a multifactorial manner. Please go to these 2 sites for videos on pyloric stenosis. Chromosomal and genetic sex depends on whether an X-bearing sperm or Y-bearing sperm fertilizes the X-bearing oocyte. Before the seventh week, the gonads of the two sexes are identical in appearance and are called indifferent gonads. Development of the male phenotype requires a functional Y chromosome. On this slide, you can see the anatomy of a Y chromosome. It has two pseudo-autosomal regions, part 1 and part 2, and a large central area, MSY, that comprises about 95% of the chromosome and has only 22 genes. SRY determines male sex. AZF encodes a protein essential to producing sperm, and mutations in it cause infertility. The SRY gene encodes a transcription factor protein. It controls the expression of other genes. It stimulates male development. It sends signals to the indifferent gonads to destroy female structures. It stimulates the development of male structures. And testosterone and dihydrotestosterone DHT are secreted, and they stimulate the male structures. This slide is showing you that mutations can affect male sexual development. In a normal male, you can see on this slide, in the prenatal development, activation of a set of genes beginning with SRY sends signals that destroy female rudiments while activating the biochemical pathway that produces testosterone and dihydrotestosterone, which promotes the development of male structures. The green arrows indicate where mutations disrupt normal sexual development, and diseases are identified in red. If you look at this, you can see congenital adrenal hyperplasia, which I will be discussing, as well as androgen insensitivity syndrome, are also, and 5-alpha reductase deficiency are shown on this slide. The sexual organs of males and females develop from the same fetal tissue. The same tissue becomes a penis in a male and a clitoris in a female. The main factor controlling this step is the presence of male hormones, androgens. With the presence of male hormones, the male organs will develop, and in their absence, female organs will develop. Without enough male hormones, a genetic male will develop ambiguous genitalia. Likewise, a genetic female will develop ambiguous genitalia if the male hormone is present. In looking at abnormalities in sexual development, we can see that pseudohermaphroditism refers to the presence of both female and male structures, but at different life stages. Living with this condition can be confusing. Consider people who have 5-alpha reductase deficiency, which is autosomal recessive. The affected individuals have a normal Y chromosome, and they have testes. The internal male reproductive tract develops, and internal female structures do not. So the male anatomy is present on the inside, but the child looks like a girl on the outside. Without 5-alpha reductase, which normally catalyzes the reaction of testosterone to form DHT, a penis cannot form. At puberty, when the adrenal glands start to produce testosterone, this XY individual, who thought she was a female, starts to exhibit the signs of maleness: a lower voice, growth of facial hair, and her muscles start forming into a masculine physique. Instead of developing breasts and getting her period, the clitoris enlarges into a penis. Usually sperm production is normal. XX individuals with 5-alpha reductase deficiency look female. The degree to which the pseudohermaphroditism disturbs the individual depends as much on society as it does on genetics. For example, in the Dominican Republic in the 1970s, 22 young girls reached the age of puberty and began to transform into boys. They had a form of 5-alpha reductase deficiency that was fairly common in the population due to consanguinity. The parents were happy that they had sons after all, and so these special adolescents were given their own gender name, which meant, in Spanish, penis at age 12. They were fully accepted as whatever they wanted to be. This isn't always the case. In a more common form of pseudohermaphroditism, congenital adrenal hyperplasia, CAH, due to 21-hydroxylase deficiency, an enzyme block causes testosterone and DHT to accumulate. It is an autosomal recessive disease, and both males and females are affected. The higher levels of androgens cause precocious puberty in males, or male secondary sex characteristics to develop in females. A boy may enter puberty as early as 3 years of age, with well-developed musculature, small testes, and an enlarged penis. At birth, a girl may have a swollen clitoris that appears to be a small penis. The person is female internally, but as puberty begins, the voice deepens, facial hair grows, and she will never get her period. Congenital adrenal hyperplasia, CAH, is present in about 1 in every 15,000 newborns. There are 2 types of this disease, the classic form, which can be life-threatening, and the non-classic, which is a milder form of the disorder. If we look at the classic form, it's usually diagnosed in infancy or early childhood, and one form of this classic disease is called the salt wasting form, referring to the fact that the body has trouble keeping the right amount of salt in the blood. The adrenal glands do not make enough cortisol, and they do not make enough of the hormone aldosterone, whose job it is to maintain the balance of salt in the blood. If it's not diagnosed and treated, the classic form can cause shock, coma, and death. In another form of the classic disease, it's called the non-salt wasting. The enzyme shortage is less severe. And in this case, the adrenal glands make just enough aldosterone, but not enough cortisol. In many cases of classic CAH, the female infants are diagnosed at birth because they have atypical or ambiguous genitalia. However, they still have normal internal female organs. A male infant with classic CAH usually appears normal at birth, although he may have an enlarged penis. If a boy is not diagnosed in infancy, he may grow rapidly and show signs of early puberty. Any infant, boy or girl, who is not diagnosed and treated appropriately at birth may have vomiting, weight loss, dehydration, shock, and even death. The treatment of classic CAH includes giving the patient glucocorticoids to replace the cortisol their bodies can't make. Extra glucocorticoids may be needed during times of stress, such as when a patient has an infection. Those with the salt wasting form of the disease also need to replace the aldosterone. Infants usually need supplemental sodium chloride. The non-classic CAH is mild and not life-threatening. Signs and symptoms might not appear until childhood or adulthood and include early development of axillary and pubic hair, rapid growth during childhood, early or severe acne, infertility or decreased fertility. Adolescent girls and adult women also may have masculine characteristics such as facial hair, acne, and/or deep voice, infrequent or absent menstrual periods. For the treatment of non-classic CAH, some patients have no symptoms and require no treatment. Others need low-dose glucocorticoids and might not need lifelong treatment. Non-classic CAH is not associated with genital abnormalities at birth and is not detected in most newborn screening programs. Please view the 2 videos on CAH. I'd like to look at androgen insensitivity syndrome, which used to be called testicular feminization syndrome. It occurs 1 in 20,000 live births. It is an X-linked recessive disorder. individuals who have this are normal appearing females. They have testes. They are 46XY. Their external genitalia are female. They have normal breast development at puberty. And the testes are usually in the abdomen or inguinal canals, and they have to remove their testes for risk of malignancy. Please view the video on androgen insensitivity syndrome. I would also like to make one final comment about pseudohermaphroditism, and that is that it is suspected whenever a prenatal chromosome check reveals an X and a Y chromosome, but the newborn looks like a girl. And I'd like you all to remember that. Please go to this link for the film, The Disappearing Male. Please go to the embryological self-study and look over the formation of the integumentary system. This begins during the second month. The broad-spectrum antibiotic tetracycline should not be administered to pregnant women or children younger than 8 years of age because it can stain the teeth. It affects the enamel and the dentin because it binds to the hydroxyapatite and it causes the staining. The enamel is completely formed in all but the third molars by approximately 8 years of age, so you should not administer this antibiotic to anyone under the age of 8. Dentinogenesis imperfecta is an autosomal dominant disorder of the teeth, and it is characterized by discoloration of a bluish gray or yellow brown color and is translucent. The teeth are also very weak and they can break off, and it affects both the primary teeth and the permanent teeth. Incontinentia pigmenti, IP, is an X-linked dominant disorder caused by the IKBKG gene. In affected females, swirls of skin pigment arise where melanin penetrates the deeper skin layers. A newborn girl with IP has yellow pus-filled vesicles on her limbs that come and go over the first few weeks of life. These lesions become warty in appearance and then become brown splotches that may remain for life. Some, however, do fade. Males who inherit the disease from heterozygous mothers do not survive to be born. Women with the disease have a miscarriage rate of about 25%. So in this disease, the teeth are affected, the nails, the hair, and the eyes. Between 50 to 75% of the individuals with IP have dental abnormalities. These include a delay in the eruption of their primary teeth, abnormal contours of the teeth, giving them a peg-like or cone-shaped appearance, or the congenital absence of both primary and secondary teeth, or they might have small teeth. Their nails are ridged, they're pitted, thickened, or they're missing nails on the hands and or feet. In some cases, painful growths may develop underneath the nail. And approximately 50% of the individuals with IP may also experience abnormal bald patches on their scalp, alopecia. This usually happens where there have been lesions that have left scars. And the hair is generally very coarse, wiry, and or lusterless. As far as their eyes, nearly 1/3 of the individuals have some form of an ocular abnormality. Here is a picture showing the inheritance of this X-linked dominant disease, and also please note the characteristic patchy pigmentation on the leg of a girl who has incontinentia pigmenti. Please now go on to do your case study on ambiguous genitalia.